Okay, so good evening, everyone. Lovely to see you all. Um, so this evening we've got Kate Timmins, who is, as you can see, Kate is here on the screen. So Kate is an epidemiologist who's interested in health inequalities. So her whole career has been research and population health sciences at Newcastle. Anyway, I've already sent you all her blurb, so you might not need me to repeat all that. But anyway, a seriously academic person and looking into pain inequality. So, okay, off you go, Kate.
All right, thank you very much, and thanks for inviting me along, and everyone for joining us, whatever time it is in your time zone. And I think I'll begin by sharing a screen. I have prepared a presentation because I am an academic. So, can people just confirm that they can see that screen for me, please?
Yes, well, I
Yeah.
can. Yep.
Yes, yes.
Great. So, as Maureen mentioned, I am a research associate at Newcastle University. I'm an epidemiologist by background, so I have actually researched several different outcomes. But Tim got in touch with me to suggest I talked about some of the recent work I did at the University of Aberdeen. So, from 2022 to last year, I was working on a project which was looking at adverse childhood experiences and chronic pain in adulthood. So I thought I'd talk a bit about that research today, but mostly it was to pull out some of the interesting things that we found from that, and hopefully that might open up some discussion, because I'm fascinated that you've got a special interest group in philosophy and ethics. So I'm intrigued to see where the discussions will go this evening. So I always begin these talks with just a bit of a warning. Adverse childhood experiences do refer to things such as abuse and neglect in childhood that are obviously disturbing for some people. Just to preface this, that I'm an epidemiologist, so I won't be talking about any individual stories or anything. It's all just counting numbers because that's what I do. Um, and I would normally begin a talk sort of describing what I mean by chronic pain, because even though I've only done research in it for a few years, I still find it quite surprising how little people realize chronic pain affects us in our society. But I gather that in a present company this evening, I probably won't need to do that. Um, so I probably will sort of skip over that, but just by way of definition, when I talk about chronic pain, I'm normally referring to non-cancer pain that has persisted for 3 months or more, but it kind of depends on the data sets we're using, how that's being defined. The other thing I will say is that I am at home and I have young children, so hopefully they won't disturb us, but please bear with me.
They got a cat. Usually cats turn up.
No, yeah, no animals,
All
just
right.
children. But they're on strict instructions to be quiet, and it is bedtime, so they should be going to sleep.
Perfect.
But yeah, apologies if we hear any cries. Um, so, having talked about what I mean by chronic pain, then I'll start talking about what I mean by adverse childhood experiences. Um, if I can go on to the next slide. Sorry, mouse is doing something funny. Okay, so what do I mean by adverse childhood experiences? Well, um, it refers, typically the definition is taken that it's something traumatic that occurs during childhood. Now, about 20, 30 years ago in the 90s, there was a paper from the Kaiser Permanente hospital group, which was sort of the seminal paper that published the first results, looking at the effects of childhood abuse and neglect on a number of health outcomes. And they chose sort of 10 experiences just because I think they had the data for them, actually. But they found that they were linked to a lot of different outcomes and behaviors and things in healthcare data that they had. And this slide shows some UK statistics, actually. So there's been a lot of research since then looking at the same experiences and linking them to a range of outcomes. And as you can see, there's a lot of different behaviors that are associated with adverse childhood experiences. I think one of the things as well that strikes people is they're a lot more common than might be assumed. I think a lot of that's driven by mental illness in parents, which is probably rising, I think, nowadays. So they are quite common. but it does seem to increase your risk of all sorts of experiences. Um, there's a growing body of research looking at chronic pain as one of these outcomes. And so when I moved to Aberdeen, I joined a Consortium Against Pain Inequality, which was set up collaboration between 5 universities. And we had a really active advisory group with people who had lived experience of chronic pain, who actually were recruited because of their experience of chronic pain. And then it turned out they all had experiences of adversity during childhood as well. They just happened to. And so this was set up to kind of look at the inequalities that are set in childhood and see if we can understand more about the causes and improve the methods in researching adverse childhood experiences and pain in adulthood specifically. Now, I'm sure there are some practitioners here, and you probably will have when I've spoken to practitioners, it's quite common that people report that many of their patients who have problems with persistent pain also report adverse childhood experiences. And there is plenty of work to support this. When you look at literature reviews, there are loads of epidemiology studies looking at correlations and associations between adverse childhood experiences and pain. However, when you get reviews where they've looked just at prospective studies, so that's where they've measured childhood adversity before pain has even developed, it's not as straightforward a story. So that has led lots of people to sort of question whether it's a real relationship that these associations are showing. Or is there something else going on? Is there some kind of bias, such as memory bias? And actually, there's been some studies that show that people who do not have pain forget adverse childhood experiences from their childhood and more likely to forget it. So there's this idea that perhaps this relationship that we're seeing across all these correlational studies is reflecting bias or some other relationship that's not causal. So unfortunately, in a perfect epidemiological study, we would measure things first to know that they're causing the outcome that happens later on. But so you think maybe people would go away and design a perfect study to look at this. Unfortunately, it's a bit more challenging when we're talking about adversity in childhood. It's not straightforward to measure adverse childhood experiences. First and foremost, you cannot measure them at the time they happen necessarily, because many of them are hidden, and there's a problem with delayed disclosure that you might not know about a lot of these adversities until people are much older, if ever. So if you just ask people in adulthood, you're always going to have this question about whether or not their memories are as effective, are as true to history. The other problem is perfect epidemiology study would follow people from childhood right through to adulthood, so it would take many years. And the problem is children who suffer adversity are much more likely to drop out of studies like that and be lost to follow-up. So then we have the bias of only including people who have less likely suffered those things. But we can hardly do a randomized controlled trial when we're researching this area. So in CAPE, we thought we'd really have a think about if we could use epidemiological methods to do better, basically, than just looking at associations. So far, I'm no longer working full time on CAPE. It is still ongoing. They've had an extension. But so far, we worked on analysing data from 3 different existing cohort studies, and they are all UK based. We did actually start the project looking globally. We did an audit of all the data sets that had appropriate data, measured adverse childhood experiences, and measured chronic pain adequately. And the best data we found was British. So we came back and that definitely limits the scope of the stuff that we found so far. So I don't know if any of these studies will be familiar to you. I'll run through them as I talk through some of the results a bit more. But the UK Biobank, if you're not familiar with it, is one of the largest studies. It's 500,000 people were recruited about 15 years ago across the UK. And they were aged 40 and over. So it's quite huge, and then they've been followed up since. The National Child Development Study is one of our older studies. That's a birth cohort study that followed up every child that was born during a single week in 1958 and has gone back to them repeatedly, the people that they could find. I think the most recent one was 2014, potentially, so they followed them up quite a long time. And then the youngest cohort we've analysed is the children of the 90s, which is the other name for the Avon Longitudinal Study of Parents and Children, or ALSPAC. And they're a much younger cohort that were born in the Avon area of England in the 1990s, so they're much younger. I won't present results from that because they still haven't been published, but I'll give you a few teasers from the work we've been doing on that just to give you an idea. So we set out, we wanted to move from this casual inference of just looking at relationships and to move towards more of a causal inference. And so there's an approach in epidemiology, causal inference approach, which emphasizes the reasoning and the methods you use that moves beyond just describing associations so that we can infer more about causality and pathways and things like that. There are a few characteristics that we need first to be able to do that. We need to establish what comes first. So there has to be some kind of temporality. We need longitudinal data so that we can measure what the cause must always come first, essentially. And then there's this idea that I think is not new to epidemiology, but I think a lot of people don't look at these sort of studies in this way. Rather than trying to find the causes of an effect, so you might look at chronic pain and then think about all the different risk factors, it's not that informative because of how they all might interact with each other and all of the other ways they can interplay. So actually, we want to get more in the mindset of finding out what the effects are of a cause, which is more of an experimental sort of mindset where you manipulate one thing, keep everything else constant, and see what the difference is from that manipulation. So we want to try and do that with observational data because we can't set up an experiment. And one way you can do that is to use what we call counterfactual modeling. So basically, we simulate what would have happened if we changed that one cause to see what the effect, or potential cause, to see what the effects are. And it's still regression based. So we're looking at patterns in the data still, but this way we're sort of just trying to isolate the effect of a single cause. And of course, we have to think carefully about what other elements are in there because we can't design an experiment to have two equal groups. So we have to try and balance any potential confounders that we have, and we do that through a series of weights. So I'll talk you through what this looks like on our first analysis. And then I actually want to move on to some interesting things that have come out. So this is just to describe the basic approach. So the UK Biobank, as I mentioned, is a really large study of 500,000. So earlier in the millennium, they recruited 500,000 people. In 2016, there was a questionnaire which asked them about their childhood experiences. So they are adults. They're all over 50 by this point. And so there is still recall here. But at this point, they do not have pain. We did separately analyse with people that had pain as well. So they were only asked 5 questions from the childhood trauma questionnaire, which are thought to pick up on neglect and abuse. And then in 2019, they included the pain questions, and the 3 that we used to come up with our outcome was whether or not they'd had pain for more than 3 months, and if that was all over the body. So in this instance, the pain is all over the body specifically. So we modelled 2 scenarios. Oh, sorry, I should probably talk about what the sample looks like. In 2019, answering those questions, the sample was 118,000 people, 50%, 57% female, and a mean of 58 years when they were recruited, and majority white. So it's not a representative sample of the UK, which I think is quite important to emphasise. I will also say that there's clearly not a full sample there. That's not 500,000, but we did impute the data so that we analysed 500,000 people. We analysed 10 sets of imputed data, so it was 10 times 500,000. So that was computationally fun. So this is what the counterfactual modelling looks like then. So imagine how many people would report pain all over if, on the one hand, no one had been maltreated in our population. So we simulate a pseudo population where no one answered yes to any of those 5 questions. And then we contrasted that if everyone had answered yes to one of those questions. If you follow the QR code, you can find a lay summary of this paper, by the way. So in men, we found that if we manipulated it so that no one had had childhood maltreatment, about 1% of the male population in this sample would have still had chronic pain all over. If all of them had, that rose to 4%. So the risk difference there is 2.6%. So that we sort of infer is attributable to just that one thing we manipulated, the presence of childhood maltreatment. In women, it was a similar risk difference, actually. So the risk difference there was 3%, but there was a much higher baseline prevalence of chronic pain all over, even when no one in our pseudo population had had any childhood maltreatment. So that's the overall approach, simplified, I hope. I hope it's understandable. So we're trying to sort of look at what that risk difference is the effect of the childhood maltreatment. Everything else being held equal in our simulated populations. But remember as well, this is not a representative population. By the way, if anyone wants to pause for questions or anything, I'm quite happy to take interruptions at any point. So just try and make a noise or wave your hand. So that's the basic finding. It essentially confirms all the correlational results that we've had. So we thought, well, yeah, that's great. But actually, I wanted to share some of the interesting things that we've managed to find with this project. So the first thing we looked at is whether or not it was memory bias. And we feel it's not just an artifact of memory bias. And we did this by using what's known as a negative control exposure, which is where we compare our analysis doing another one with a different exposure. So instead of childhood maltreatment, we did the analysis with childhood sunburn. So the same questionnaire where the participants were asked whether they had had neglect or abuse, they were also asked if they'd ever had childhood, they'd ever had sunburn that was painful for 2 days or more or caused blistering. And the idea being that this is still a negative memory. And so if people are forgetting it because they're not having chronic pain, then we'll probably still see an effect. And we can say that it's probably something to do with memory. Well, what we found was that there was still a small effect, but it was a much smaller risk difference than that of childhood maltreatment. So we don't know for sure. This doesn't prove anything, but we could infer that the effect of childhood maltreatment was more pronounced and therefore probably not just to do with memory. So that was one of the things we've shown for the first time using the UK Biobank data, which I think is hopefully interesting. The next thing that I think is quite interesting is it stemmed from discussion with our advisory group, where there was lots of talk about having triggering events in adulthood. And so we wondered, is it just about childhood maltreatment, or should we look at traumatic and stressful events in adulthood as well? And I've given the game away because it's in the data, it wasn't just about childhood events. So in the UK Biobank again, they also asked about stressful life events in the 2 years prior to the questionnaire in 2019. And those were things like serious illness or injury to themselves or a relative, death of a relation, marital separation, or financial difficulties. And we found that actually the risk difference here, I've plotted it on a forest plot instead, the risk difference for adult stressful event was similar to that of maltreatment on average. And actually, interestingly, people who had experienced both, when we simulated both, it was over and above those 2 risk differences added together. So this suggests that people who had childhood maltreatment, if they then experienced life stressors, the effect of that was exacerbated as they were older. So the next thing that I think was quite interesting was we thought, well, is it just that experiences of adversity in childhood predispose people to have all sorts of poor health outcomes across a whole range, and behavioural and social and economic. Or is chronic pain actually just one of many things, or is it something unique? So we thought we'd do what's known as an outcome-wide analysis and look at all health problems, a range of health problems, sorry, not all of them, a range of health problems in midlife, and see how they were related. And again, here we go. The interesting thing is that not all of the health problems were equally affected by ACEs when we analysed it. For this study, we looked at the National Child Development Study, that birth cohort I mentioned. Again, there's the QR code if you want to look up the lay summary of our publication on this. And this is a much longer study. They collected data, a lot more waves of data collection. In the early years, they had interviews with mothers, and they had questionnaires at schools with teachers and health visitors as well. So there's a variety of sources. And these are some of the adverse experiences that they picked up at the time across childhood. So these are prospectively collected, and you can see it's a much broader range than any of the other things that I've showed you. But they also asked about childhood experiences in adulthood as well. So this hopefully would pick up some of those experiences that might have been not disclosed during childhood. And again, there's quite a lot of different experiences there. And then in 2008, they have had more recent waves from this cohort, but we used questions from a health questionnaire in 2008 because specifically, during the interview, they asked questions about pain, which was what we were interested in, as well as the other health outcomes. And again, it's not a representative sample. It's much smaller than the UK Biobank, so it's 16,000 people that they followed up, and they had a quite high attrition. It's probably not as high as you'd get nowadays, but about 50% have been followed through life, and about half and half male and female. But again, it's majority white, so it's not a representative sample. So these are the outcomes that they measured in 2008. So severe pain, this time they asked about the previous 4 weeks. So they asked how much bodily pain people had had in the previous 4 weeks, if they'd had it for 4 weeks or longer. And we combined, if people responded severe or very severe, we combined those. So it's just people with the most severe pain. They were also asked if they'd ever been to see a physician or a specialist or been to hospital with a mental health problem. And then they had a whole list of more than a dozen health outcomes to respond yes or no, whether they had any of these problems. And we took all of the ones that had a prevalence of 5% or more because we had to do that for robust modelling. So we repeated the same approach that we did with that UK Biobank study, where we're doing counterfactual modelling. This time we did it again and again for each of these different outcomes, and we put them all side by side so we can look at the risk differences and compare them, essentially. And here you can see quite clearly that pain and mental health problems are leading the way in terms of the impact of adverse childhood experiences on these outcomes at age 50. Whereas some other of these health outcomes do not appear to be associated. And in women, it's not dissimilar, slightly different pattern, but again, mental health problems are clearly affected by modelling the adverse childhood experiences, and pain and back problems and gastrointestinal problems are also showing a strong effect there. So our conclusion there is that there maybe is something unique about mental health problems and chronic pain. It's not just that adverse childhood experiences affect everything. So there's variation across the outcomes. There's also variation across the different types of adverse experience. So this is quite a busy slide, but which I debated about showing. But then when I was talking about this with my colleagues, they said they asked about this, so I thought maybe I should share it. So this is a heat map showing the size of the risk difference for all of the outcomes across the bottom there, with different types of adversity on the left, measured at different points in the life course, some of them multiple times. So the closer it gets on the spectrum to red, and I apologize if this is not colorblind friendly, the closer the cell gets to red, the bigger the risk difference. So you can see here, for example, criminal activity of a family member is showing quite big risk differences across that row. And in particular, for back problems, it seems to be quite strongly associated. The columns or the outcomes which have the most sort of oranges and reds there are severe pain and mental health problems, as you'd expect, but it's not across all of the different types of adversity. I should probably also say, though, that that was taking the point estimate of the risk difference. So we did also plot the lower confidence interval, which is kind of gives us a more conservative estimate. So that little plot in the bottom right there shows the lower confidence intervals. And you'll see a lot of the risk differences are showing to be less, not of interest, I guess. But mental health problems and severe pain are still showing up as having a risk difference, even taking the lowest estimate from those confidence intervals. So I probably should have said this was men only. We separately analysed men and women. In women, again, it's similar sort of pattern where we've got severe pain and mental health problems across the different types of adversity. And again, mental health problems remains even if you take the more conservative estimate there. So that led us to think what's going on then. So I've borrowed this infographic from Nelson et al., who tried to hypothesize what's the unique relationship between adverse childhood experiences and chronic pain in adulthood in particular. And there's this idea that there was a sensitive period during development when traumatic experiences and stresses will either cause epigenetic changes or disrupt neurodevelopmental stages that then leads to a disrupted stress response or some other biological change later on in adulthood. So we thought, if that's the theory of what makes the relationship with chronic pain unique, can we look at that? Can we look, is there any data that has measured adverse childhood experiences at these different developmental periods during childhood? And there's some worse than others. So this is the teaser that I'm going to show you, because I'm not going to actually show you the results because we haven't yet published them. But I can just tease you with the finding that the impacts don't appear to be confined. In most cases that we've looked at it, we didn't find evidence of a sensitive developmental window or a sensitive period effect. So it seems to be that accumulation of adversity is really what predicts risk of chronic pain, and it doesn't matter if that happens in the earliest childhood or mid-childhood or adolescence. So the final interesting thing I thought I'd share tonight is when we're thinking about, okay, if it's not epigenetic or particular neurodevelopmental sensitive window, are there other causal pathways, which I think we could probably assume there are, so via mental health, for example. We thought, can we see those patterns in the data? So looking back at the UK Biobank, this is a recap of that first result that I showed you. So just to remind you about the risk difference that we saw when we compared the pseudo populations there. Of that risk of about 3%, we found that a third of it could probably be explained by things that happened in between. And we could only analyze those that were captured in the data already. So there's only 4 that we looked at, but these 4 captured about a third of the risk difference. And so that was anxiety and depression, index of deprivation based on where they live as an adult, sleep problems, and then the question was about having someone to confide in or not. And I think anxiety and depression really was driving the bulk of that. So that's the things I think are most interesting from the work that I did at Aberdeen. So I just want to finish with some of my own reflections and maybe open it up to everyone else for discussion. So I'm sort of interested in the opportunities and limitations of epidemiology and whether or not we can use this data to analyse individuals' lives. I feel like chronic pain is one of those that it really does have a life course development, and epidemiology, I think, is possibly one way to try and capture data across the life course from multiple different sources. At the same time, I also often have soul searching about whether or not finding out more about the life course and these sort of pathways actually will improve the prevention or management or treatment of chronic pain. So I'm hoping people might be able to reassure me. I sort of think to myself whether or not there are biographical determinants of health. Is that conceptually or practically useful? You know, is it if you go through a stressful life event, should that be a point of intervention potentially? Is there a preventable intervention that we can do there? And then on other things I sort of wonder about is about how our etiological understanding affects the experience and management of pain, by which both at the societal level, like not just as practitioners or researchers, but you know, societal in general, but also people themselves when they experience pain. I do sometimes wonder, there's an awful lot of talk about adverse childhood experiences and pain, but I don't think it's talked as much about adult trauma. So I do wonder if we've been neglecting that bit. But then, of course, I can only analyse what's measured. That's the real limitation of epidemiology. And there's all sorts of other things that might be at play. And there's interesting research coming out about concepts about being heard and being believed and being dismissed, or perceived injustice, intergenerational effects and intergenerational trauma, and what the role of poverty and socioeconomic inequalities has in all of this as well, which is not simple to disentangle. So those are just some of my reflections. And now I guess it's probably a good point to open up for discussion, if that's your usual mode.
Lovely. Yeah, thank you, Kate. That was brilliant. If you want to stop sharing and then we can see everybody on the screen.
Okay.
Lovely. Okie doke. So anybody want to do a hand raise or wave? No. Mary.
Hi, my interest is in resilience, which is the kind of, I know nothing about statistics. I flunked every statistics class, but kind of conceptually, I understand that if you're looking at all these risks, there must be many people, I know there are many people who've had lots of adverse childhood experiences and yet don't have chronic pain, don't have mental health problems. I wonder if somehow your data captures those people. Thinking of your questions you had at the end about what are the implications for this, how do we use this material to intervene, are we looking at resilience as well? Because to me that suggests a pathway for intervention.
Yeah, no, that's a really good point. And actually, I mean, I'm not working on CAPE anymore, but I'm still involved in the last analysis, and that was one of the things that came up as the last thing they want to try and look at, is to see if there's any sort of buffering factors that might enable you to predict who is going to, following an adverse experience, who is going to develop chronic pain or other outcomes, and who might be more resilient. And I think there is also some interesting research, I think, from Australia about positive childhood experiences and how that might counterbalance adversity. What I will say is that it's difficult to know what to measure. So from an epidemiological standpoint, it's really hard to kind of think, what's being asked out there. I mean, there's some things kind of, you can take the flip of those mediators that I talked about. So having someone to confide in,
Yeah.
if not the inverse. If you did have someone to confide in, you might assume that that is a kind of a buffer or protective factor. But yeah, it's something that I think for the rest of CAPE we might try and find a data source that would allow us to look at that. Yeah.
Thank you. Anne.
I'm currently working in a deprived area, running some pain workshops and pain self-management workshops. And it seems to me that your neighbourhood or your community affects your ability to be able to manage your pain. So consequently, you'll feel your pain more because of the determinants of how and why you're living. Do you think that that's a possibility, that that's why some people feel their pain more acutely, their chronic pain more acutely than others?
I don't know is the honest answer to that. I've not seen data at a small enough geographical level to be able to look at that. But I do think, sorry, I forgot what I was going to say there. Oh, that is annoying because it was, yeah, sorry, it'll come back to me. Hopefully it'll come back to me.
Okay.
Oh yeah, so what I was going to say is that I think one of the things I want to do, so at the moment I'm not working in chronic pain, but it is something I want to return to. And one of the things I'm interested in is how there are different levels of prevention, and different levels of inequalities as well. So we can have, you can think of primary prevention in terms of preventing pain in the first place, secondary in terms of stopping pain becoming persistent, and then tertiary, trying to prevent poor outcomes from having pain and living with pain. And I think it would be quite interesting to kind of, rather than just trying to, from an epidemiological viewpoint, just looking at it as a single thing, trying to look at it at these different levels and looking at the different inequalities at each level. So I presume, I haven't looked at the data, but I think it would be really interesting to see that there are inequalities in the development of pain to begin with, but also inequalities in the experience of living with pain. And I think there's possibly something that we could intervene on to try and prevent those.
Thank you.
I hope that's answered your question.
Sorry, Amelia Swift has put something in the chat. So I don't know if you want to say what you wanted to say, or shall I just read it out, Amelia?
Yeah, it's probably easier to say it. Thanks, Maureen.
Okay.
That was absolutely fantastic, Kate. Thank you. I was just wondering about the regression analysis, because I was interested to see anxiety and depression treated as a separate factor to severe pain. My research was on the link between depression and anxiety and pain, and of course there's a link between anxiety and depression and ACEs as well. Is that a problem? I'm assuming not, because you're an experienced epidemiologist.
No, well, it is and it isn't. It is a problem. But so because we weren't designing the studies ourselves, we're using cohort studies that have been set up to measure all sorts of things. We could only use what had been measured at whatever particular time points they had been measured at. So we were limited in when we could look at anxiety and depression, for example. So in the UK Biobank, we could put it in as a mediator because they did measure it multiple times. In the National Child and Development Study, I think that was one of our outcomes. And possibly we could have looked at one from earlier, but I can't remember what age they measured it earlier. But I think that's definitely something I wanted to do, but we didn't have time to do, is to look at how it can potentially be cyclical, almost not cyclical, but it's not just a one-way pathway. So you might have the anxiety and depression and then the chronic pain, and it feeds into anxiety, which might feed into chronic pain. And there are some emerging forms of modeling that might be able to capture that, but you have to have data that's often enough to be and measured in the same way consistently to be able to do it. So it's not something we managed to do. Some of the younger birth cohorts might be set up for that, but they were still quite young when we were planning which cohorts to analyse. So they were just emerging into adulthood. But I definitely think that's something that would be important to look at.
Thank you. Can I ask something? Does forgetting about it help? You know, it seems that sometimes people have had early life misery, but they forget. And I'm just wondering if those people are the ones who have chronic pain but don't remember the ACE experience, because it's impossible to know, isn't it, really? But sometimes forgetting some bad stuff is quite useful to do, just not to keep ruminating about
I
that.
have wondered as well if some of it reflects differences in memory. So some people have really good memories and they remember
Yeah.
everything that happened in childhood, and that just plays on their life. It plays out again and again.
And I suppose if it's traumatic enough, it's not processed fully, is it? It's like PTSD, you keep going over it. So maybe that.
Yeah, and that, I mean, you brought up another, like, as well as the anxiety and depression, I think the relationship with post-traumatic stress syndromes is one that is not really fully unpacked yet.
Yeah. And just one other thing, it must hinge to some extent on what your basic personality is like. Some people born very laid back, aren't they? And some much more stressy. So
that's not something I would easily measure as a
No, it's very difficult to measure.
Well, I take my hands off that. That's psychologists.
I don't know. Maybe I've just got the wrong thing, but I think I was told that 50% of your personality you're born with, and the other 50%, well, half of what you get is what you're born with, and the other is about your environment and your upbringing and all the rest of it. So,
and I think as well in this case, we found when you get the different aged cohorts, they respond differently. So,
yes.
We've looked at some data from the Lothian birth cohorts. They were born in the 1930s. And of course, they all lived through the war as well. So in many ways, they probably all experienced childhood adversity. But also they just sort of went, well, this wasn't an adversity. This was just life. So I think there'll be some cohort effects as well that would be
be very interesting. Just one other thing. Do you think it makes a difference if they're the only child or if there's a group of children in the family? I'm just curious about that might help
I don't know. I haven't
you if you've got, no, not something we can
look to that, but that could be interesting.
Yeah. Okay, sorry, Mark.
Thank you, Kate. That was really fascinating. And I had a question, but then when Maureen made me think of a different question, so so I was thinking, I use mindfulness a lot to manage my. Sorry, I have lived experience of chronic pain, and I'm a member of the BPS Expert Patient and Care Committee, and so I use mindfulness extensively, and I was taught it in a pain management program, and sort of in follow-up education and training in that. So, and I find it very effective. And one of the things that I think is often sort of said about mindfulness is that, as you know, is that the more time you spend thinking about, or the more time you are sort of introspective and dwelling on your pain or on your other issues, your stress and anxiety, etc., the worse your pain tends to be, and that's part of the rationale, isn't it, for mindfulness being applied to chronic pain, is that the more you can focus elsewhere, then the less effect the pain will have. And I do find that to be true in my case. But I wonder whether that plays then into what you're saying, in the sense that if people who are, there might be a personality type, or it might be for whatever reason people start being more introspective as a consequence of an experience, and that then lends their personality to be more prone to experiencing chronic pain. I don't know. I'm just positing that's something that popped into my head when, as a consequence of what Maureen said. But the other thing I was going to ask was about, because I know you're an expert in health inequalities, whether there are sort of intersections between the broader health inequalities and this specific issue of adverse childhood experiences.
Yes, yeah, definitely. It's one thing that we tried to sort of equalize a bit more in our analysis. But yeah, there's definitely socioeconomic patterns in adversity, particularly for some things like substance use. And obviously deprivation, some people say, is an adverse childhood experience in itself. Poverty is as well. So there are patterns there, as well as patterns of chronic pain as well, in terms of socioeconomic status and gender, and I believe sexual orientation and ethnic group. We were quite frustrated because we wanted to look at some of these inequalities a bit more, particularly in terms of ethnic group. We're quite frustrated about how we weren't really able to find cohorts that had a good enough representation to enable us to dig into that, which is quite frustrating. So that might be something they try to do for the remainder of Kate, but I just don't know if the data's there, sadly.
Okay, thank you. Vorko?
Yes, thank you, Kate, for your excellent talk. I have to explain that I am a pain psychologist and a psychoanalyst. So I've met people with pain, and then I've talked to people about their childhood experiences. And I was wondering, most of the people that I meet as a met as a pain psychologist, they did have adverse childhood experiences. Not all of them. Some of them were like born prematurely, and therefore, they had pain for many, many years afterwards because of the procedures that they've done. But anyway, but then daily I speak to people about their adverse, or they tell me about their adverse childhood experiences, even 4 times a week as a psychoanalyst. But not all of them have pain. But most of them have adverse childhood experiences and intergenerational ones that they come to a psychoanalyst or psychotherapist. So that part was very interesting about the intergenerational load that people come and carry with them. And one thing that I thought about, which has something to do with the one previous response, was about the ability to symbolize. So some people can can put it into words and therefore relieve themselves of that pain or the burden of the pain. But some people cannot. And then the body takes that burden and carries that pain in them. It's not a cause and an effect, but it is, I've run into that many times, and I wondered if you have any thoughts about that.
It's not something I've thought about before, I have to say. Obviously, I don't have the experience you have. I think that's really interesting to hear, though. And, I have seen a presentation once where they were talking about the different cultural contexts of pain and the different language around pain. All of that, I think, is really quite fascinating about how people express it. So I definitely think there would be, I do feel there is something about the expression of, or the communication of your pain, and yeah, but it's not something I've researched. It's not something that's easy to do from a population level. But I think it's probably important to try to triangulate with different sources of data as well. So, if you can look, what we can measure at population level probably needs to sit alongside more detailed, smaller scale research to try and understand more. I don't know, that's probably a dissatisfactory answer, but no, it's really interesting to hear.
It reminds me of that book, The Body Keeps the Score. Have you read that, you guys? Probably have. The Body Keeps the Score. It's quite an old book now about how emotional distress is somaticized in symptoms. Walker, did you have another question? Still got your hand up? Oh, you've muted. Oh, no. Okay. Right. That's okay. Yeah, one of the things that was on one of your slides was about birth weight, Kate. I mean, which way does it work if you're a small baby or a large baby?
So I think, and Vorko, is that your name, was talking about the perinatal experiences.
Yeah.
Birth weight was what was captured in that study, and we used that as a proxy of gestational age. So it being more likely to be lower birth weight if you had an early birth, because that has been associated with chronic pain as an adulthood.
Oh,
It's
really?
also associated with adversity in childhood, or some people consider it to be an adversity in itself.
Yeah. You wonder how much they remember, because they obviously undergo some awful being intubated and ventilated and all without any kind of anesthetic. I mean, it must remain somewhere in the unconscious, but maybe not, you know.
But again, it's an interesting thing. Like, and again, it wouldn't be that difficult to set up a study to look at preterm births or people that have had interventions in the early days and see, you know, which of those don't go on to develop pain. I think is just as interesting.
When an adult is put on a ventilator, they get sedation, but premature babies just get intubated and ventilated. I mean, it's quite barbaric, really.
And pricked every day for their blood
Always
values without any pain medication.
No pain, no, nothing.
So it's not psychological, it's actually physiological.
Yeah.
They developed chronic pain more easily than the people that don't have those experiences because their nerves are just, you know,
sensitized.
Yeah.
Yeah, you can imagine that it would be pretty grim. I think in some places, was it in I don't know, it was Brazil or Bolivia, somewhere where they didn't have intensive care for premature babies. They didn't have incubators, so they would strap the tiny child onto the chest of the mother, and apparently they had some really good outcomes. You know, she maintained the body temperature. They weren't on a ventilator. You know, I don't know. I haven't got any of the figures, but apparently they had pretty good outcomes comparable to big sophisticated hospitals where they had all the gear.
I think in Canada, at the University of Calgary, they do a lot of work in pediatric pain. So I think they've done lots of interesting things about early life, but also childhood pain as well.
Oh, right.
Okay. Yeah, really interesting. It's worth looking up if you.
So how would I find?
I think I can't remember what the group's called, but Melanie Noel is one of the researchers.
Noel.
Noel, yeah, like Noel.
Okay. Thank you. Yeah.
See there's something in the chat there as well about Sarah's put something about moving beyond the biomedical model and trying to validate a causal relationship to promote more acceptance of it and more focused work. Yeah, that's why I feel like there is value to doing this sort of work still, trying to capture the social and the psychological and the medical all together.
Yeah.
I was speaking to a GP last week, and he was talking about how just a simple thing, it would be interesting to look at where a pain management clinic was situated because so many of them are in hospitals. And he was wondering, you know, that straight away sends the signal that it is a biomedical problem to anyone that's attending the clinic. So quite interesting to see if there's a difference where you site your clinic.
Of course, yes. Okay. Sarah, did you want to say anything about your chat message? I don't know if you want to.
Not particularly. It was just, you know, I thought the work that you were doing, Kate, was really interesting and really worthwhile. And the fact that you said sometimes you have your soul searching moments where you're wondering what kind of impact it would have. To me, as I've put there in the chat, I think it has the potential to be extremely impactful because even people working within pain clinics will sometimes have that. I mean, I hate it. It makes my toes curl. Correlation isn't causation. You think, well, okay, maybe not, but that's for the statisticians to tell us. But when you anecdotally see the same patterns again and again and again and again, you'd be blind not to see that there is some relationship there that has to be understood. And in understanding that, and if it is a causative relationship, then we start focusing our attentions in the right direction as opposed to just keep having more scans, keep having more injections, keep having more drugs. So yeah, it absolutely frustrates me that even people in the pain world, the clinicians, will sometimes sort of veer away from some of these psychophysiological things because as yet statistics don't show us the mechanics and that causal relationship, even though we see it in the patterning, the anecdotal patterning. So yeah, keep doing the work, Kate, please do.
Yeah. When we had a cohort of Bangladeshi patients I was a GP in the practice, and the older women who weren't really fluent in English, they would complain of burning all over. And it was usually emotional. They didn't complain of pain, it was just burning everywhere. So it took me a while to work it out, what was going on. I don't know whether they had pain or not, but the way the language they used was burning. And apparently that's not an uncommon expression. But also the other interesting thing, when you're treating somebody for depression, antidepressants are often used for chronic pain, like tricyclic drugs. So it seems like there's an overlap between pain and emotional distress, which has common treatment.
Oh yeah, and Francis is talking about the Dunedin, I pronounce that right, Dunedin longitudinal study. We did consider that. It's a New Zealand study which had lots of really interesting data. And the reason we didn't analyze it was because it was quite small relatively. So I think towards the end there were less than 2,000 people, I think, which was our cutoff for robust statistics. But it's a great longitudinal study, so there lots of interesting stuff has come out of that.
What were they looking
at? I would say it's been a few years since I read any of the results, but they did look at the parental intergenerational effects, and it's something that I think we could look at with that Children of the 90s study. They've looked at both chronic pain in the mother and also adverse childhood experiences of the mother. And now they've got children of the Children of the 90s. So potentially there are 3 generations worth of data going to come out of that study in the UK as well. So it's something I think that definitely hasn't, definitely has scope for more work to come from.
Yeah. Okay. Anne.
You saying but the word burning and what Marcus said about mindfulness has reminded me that I went to a workshop recently, and there was a gentleman there that had worked with some of the ambulance crews that had been the first responders into the underground on the London bombings.
Yeah.
And they had suffered with PTSD and long-term chronic pain. And he was able to reduce their chronic pain dramatically through tapping.
Oh, yeah.
And he's now works with the Southwest Ambulance Trust, working with the responders to horrendous things. So it's possible that maybe there are some things that can lessen that memory bank of the bad memories that cause the chronic pain, or work towards help, us feeling chronic pain. It was quite phenomenal. He was saying that one woman who had been suffering, it took 3 sessions of tapping, and she was virtually sort of about the 3rd person down into the underground. And things like, she couldn't, the smell of pork cooking would give her the unbelievable chronic pain because of obviously what had happened to the people in the underground and whatever. And within 3 sessions of tapping, that disappeared. So is it possible, I'm wondering, whether we can alter how we remember these things, the adverse events, whether they be childhood or in adulthood.
So were they doing the tapping afterwards? Yeah, sorry.
Yeah, I was going to say I don't know. I'm not familiar with tapping, so I was going to ask what is tapping.
It's you tap on certain bits of your body, head, I think. I'm not an expert. I went to this workshop, so it's head, then it's here,
Sarah
then
knows.
it's here, there, under your nose, isn't it? Under there, and then on your collarbones, and then under sort of like your hip. I'm wondering whether it's possible to is that like mindfulness is getting the body to go, or the memory and the body to go somewhere else rather than it being so focused on the pain or the reason for the pain. And I'm always concerned that we're giving people more reasons to feel their pain by saying, if you know, sort of it could be linked to adverse childhood events or trauma in adulthood. I don't know. I having had both and living with chronic pain, I often wonder if I kept telling myself to be healed, would that heal me?
Worth a try.
Be healed.
There you go. You've done it.
Yeah.
Sarah.
I think the EFT technique is more similar to EMDR in that you're trying to uncouple the associations that the body and the brain holds between the story of what happened to me, and the physiology that gets trapped inside of the body. And these are the sorts of techniques, things like, well, EMDR is now very well kind of respected, but things like tapping sit on the outside of mainstream medicine. And the work that we've been listening to tonight is the kind of work that could completely change the landscape of pain treatment, because it validates stress, physiological, psychophysiological stress, as being a causative agent in chronic pain for some people, which will force us all to start looking at these techniques like EFT tapping that are currently sort of marginalized and thought to be a little bit sort of witchcraft by mainstream medicine. And again, those of us that have seen the amazing transformations in patients' lives are really keen to use these techniques that have no side effects, are free, are very self-empowering because the person is doing it themselves. But at the moment, these techniques are being kind of shunned because they don't have that sort of credible NHS stamp of approval, which they will do if we all start taking some of this data, this population level data, more seriously and really start seeing those patterns. One of the other things I was going to mention was that I've been recently looking at implicit attention testing in terms of pain. So being able to separate when someone says they have a conscious awareness of fear of pain, potentially, versus what is actually held unconsciously as a relationship to pain and fear of pain. And it seems like implicit association of fear of pain is much more predictive of pain than is somebody's conscious self-report of fear. So I think, again, this links in with the memory problem that you were talking about, Kate, that not only may it be that some people are not necessarily remembering their early years, but there's also something very different about our cognitive recall versus what's implicitly held. And again, that links in with the whole Bessel van der Kolk body holds the score idea. So there's no way we could do that with this big data, because then, you know, implicit attention tests aren't carried out very often at all. But, you know, we haven't got the data. We haven't got it in the large numbers, but we haven't even got it in small numbers, because some of this stuff it's not possible for people to report accurately, because implicitly there are things that are held that they're not even consciously aware of. So, you know, we're doing the best we can, but some of this data, I don't think we're ever going to be able to get it at all, really.
I'm hoping we started last week teaching our little group a bit of tapping. Not me, because I'm not the expert, but somebody that's been trained in it. It'll be interesting, you know, in a few weeks to see whether any of them are benefiting. You know, because I think that there is a way for, as you say, EMDR tapping and those at the moment sort of like what they are described as non-medical approaches. So yeah, so I should look forward to some research being done.
There must already be research on tapping, don't you think?
There might well be, but I haven't.
No.
It hasn't crossed my path yet.
There's very little. I just looked it up.
There is. Oh,
hey.
So you know where to look, and you see a mere mortal, non-medical mortal. I don't know where to look.
Well, you can just go on Google, or you can look on PubMed, PUBMED, and you can put in the search box any
NFT.
EFT must
tapping. Yeah, that's it. Okay, thank you so much, everybody. That was brilliant.
Peter.
I was just thinking about the usefulness of knowing about adverse childhood experiences. Is there the usefulness of knowing that a particular patient sitting in front of you can recall childhood adverse childhood experiences, and it struck me that the evidence for its usefulness must be to a large extent anecdotal. And I was wondering whether any of the work or any of the other pain psychologists or pain therapists present has any could tell us a story of a patient who had found particularly helpful to recall, or possibly not helpful. I just throw it open to the audience. No?
Well, I mean, I can talk a little bit about when you using hypnosis for people who've had an adverse event that they remember and is troubling them. An adverse event in their childhood when they weren't very able to deal with it and they didn't have any power. You can get them into a nice light trance and then talk about going back over the years to roughly the time when this happened to them, but for them to be floating above the event and then looking down and seeing the child self. And you can get them to send them positive thoughts, or you can get them to actually go down and rescue the child from it. There are ways you can recover them from that. I mean, I'm not telling the story very well, but anyway, it's timeline. You can talk to them about going back and forgiving themselves, and they weren't able to deal with it all at the time because they were a child. So there are ways using hypnotic techniques. Peter, do you want to say something else there? Peter, did you want to?
No, I was just wondering whether anybody got a story about any particular patient that stands out in their memories. No?
Nobody's admitting to.
Oh, Mary has put her hand up, yeah.
And Andreas, yeah.
I am a psychotherapist, and I've got two masters. I've got a master's from America and a master's in the UK, and some other postgrad stuff, and none of that addressed trauma. So the majority of my CPD ongoing is about trauma. And I got myself a trauma supervisor for a while. And he always said to me, he's a fantastic man, really, really wise. And he always said, first with the body, then with the mind. So you can't get to, when was your earliest memory of blah, blah, blah. You have to work with the somatic presentation, with breathing or whatever's going on in their body. I'm also trained in EMDR. And again, we do very little talking about the actual thing that bothered them. We talk about, well, what's happening in your body? Oh, my throat feels really tight. Okay, we'll go with the feeling in the throat. So yeah, in answer to your question, Peter, about, you know, when you have people in front of you who've got excessive chronic trauma and so on, and or chronic pain, you have to start with the bit that's presenting. If you launch into the memories of the trauma, you just do a lot more harm than good. And I have to admit, in my early days, I did. And I remember those words, first with the body, then with the mind, and it has absolutely transformed my practice.
Brilliant. Thank you, Mary.
Thank you.
Peter,
Can
did
I
you
say?
want to say something else? Vorko's next, yeah?
Yeah, I could answer to Peter's question. I have several patients that I've treated, but these treatments are long. They're like years, 4 years and 3 years long. So I don't have a very short answer to it. But I have some cases where there's been usually pain that's been caused later on in life. But why it is developed as a chronic pain has some connections with their childhood, and also these intergenerational. So like the patient and their, let's say, father or mother would have the same pain in the same area of their body for whatever reason. But the causes or the connections actually between the present day pain and the previous pain, or the ACEs or whatever, whether they are physical or emotional, the background reasons, they take a long time to unfold. And it usually happens in the interaction between a therapist and a patient. So sometimes it's me having the pain. Like, for example, I had to go to an ear specialist because I had an ear problem, having listened to this person for 3 times a week, just giving me the whatever they had experienced. So my ear got infected, and they threatened to pierce the eardrum in my ear. And only a year or 2 later, I found out that this patient had her eardrum pierced several times starting when the patient was 5 weeks old, of course, without any pain medication. But I had to go through the pain first to really feel it in my skin, what they have gone through. So this is one, and this patient had surgery for another condition that then developed into a neuropathic pain. And this treatment took 4 years, but she was able to get rid of the pain medication and to be able to, have children, because with that medication she could not have, and also to be pain-free. So, but it's a long story. It's a long way, but there are cases, at least I have a few, 2 of them actually, that I have permission from the patient to use it in my training. I train other psychotherapists. So yeah, there are cases, but there's no cause and effect study. It's just clinical case studies.
Very
but they convince me.
Yeah. Thank you. Andreas.
Yeah, I mean, as a jobbing pain consultant still, I find it, and to briefly answer Peter as quickly as I can, I find it incredibly helpful to have that approach and have the understanding that trauma may have a role. Rather than a memorable case, I mean, there were 3 patients today with widespread pain alone who benefited, I think, hugely, in the sense that their eyes sort of, really were amazed that somebody finally perhaps got it and understood, and that there was even a relationship being created. So in a clinical practice, I find it immensely helpful to have that approach. It really makes a huge difference with the hardest, most difficult, most complex cases. And as I say, rather than one person, it's 3 or 4 patients a day where that link is increasingly understood as part of the bigger picture. Thanks.
Yeah.
And I think that's something that came out from a lot of our advisory group discussions as well, where they're not being believed, both in terms of their pain, but also in terms of their childhood experiences, is a really big theme. And if you look at the qualitative literature as well, not being believed seems to be, it crops up all the time in people with pain. So I guess that's what you're sort of picking at. If you start to show that you're listening, then they start to feel they're being believed, and maybe there's something in that.
I remember hearing a nurse on the radio one day, some while ago, and she'd been looking after a war zone trauma patients, and I mean, continually dealing with these severely injured people, so quite traumatic for her. And the interviewer was saying, "Oh gosh, how did you deal with all that?" And she said, "I deliberately forgot about it." So she'd use this forgetting technique. So instead of going home with all the stuff buzzing around in her head, she had this device I don't know how she did it, this little strategy where she could just stick it in a box, and that was her coping mechanism. So maybe some people do that. I think that's what I was thinking, some people who've suffered trauma, maybe we all have the ability to just discard it. But you wonder what will happen. These children who've been separated at the Mexican-American border from their parents and put into cages, whether years down the line, these people will have all over pain. And children from war zones are bound to be, aren't they? Bound to have traumatic lives.
Yeah, it's not an area that I've researched in, but I think it's important because they often aren't captured either, are they, in the traditional cohort studies and the work that a lot of people do on pain.
No, quite. And it must make a difference to their physical growth and all the rest of it. I think traumatized children are a bit shorter, aren't they? I'm not remembering that terribly well, but I think children who live in Gaza are about 9 centimeters shorter than the equivalent child in other places. They haven't got, might be partly nutritional, but bombs going off everywhere must be quite traumatizing. Anne.
Sorry to be another question, but when was it Sarah talking about resilience? Does that mean resilience to adversity, in as much as does that play a part in how we personally feel our pain?
I think Sarah's gone now, I think, hasn't she? I think she was more getting at that might be part of it, but I think she was talking about things that protect people from developing pain as a result. So it might not just be individual or personality characteristics. There might be, I imagine, having financial resources and social resources are probably going to help you be more resilient to an adverse experience. I mean, one of the interesting things that comes out, and it's quite robust, is that bereavement during childhood doesn't seem to have an effect on chronic pain or lots of other outcomes. It seems to be sort of neutral in terms of some people obviously get pain, some people don't. So I wonder if that's to do with, it could be an isolated experience, but also maybe if people are supported well during that process as a child, that's one of their resilience factors. So it's not necessarily about the individual. I think that's what Sarah was getting at, though.
So it's about the environment around you as well, as well as what you yourself feel. The reason I ask is, going back to single stories. I mean, my dad was injured in the war, he lived for his life from the war onwards with a bullet lodged in his windpipe. But he still became a sportsman and did all sorts of things like that. But that's because that was expected. You weren't expected to, sort of go on about your illness or the fact that you were perhaps not as well as you should be or whatever. There was that. So is that maybe what we've lost a bit, and why this level of chronic pain is so huge?
Don't know, but I do feel like I remember reading stories from war injuries where it didn't go as well for them, that it wasn't acknowledged. So I feel like it can go either way. We can't pinpoint why. I don't think
it's fascinating, isn't it, this pain thing?
Very. Yeah, very. There's the other interesting writer, Steve Biddulph. It's quite an old book now, Raising Babies. I don't know if anybody's come across that. And he was saying that, the first 3 years are absolutely crucial in terms of resilience, and that children put into childcare facilities that are understaffed and people aren't very nice to you as a baby. They've measured the cortisol levels in the saliva, and these babies have very high stress levels, and they're not able to express any of it. And it doesn't go down over the weekends or during holidays. So your whole adrenaline, cortisol levels get set high and they stay high. So these are the people who become very anxious as adults. That's the theory. But he got into big trouble because all the feminists were going, oh, we don't want to stay at home looking after our babies. But he said, oh, you just have to have good quality childcare. It doesn't have to be the mother one-to-one. But, it can have a permanent effect. It resets everything. And you can see evolutionarily, it would be important if you're living in a dangerous place as a tiny baby that you've got to be on the red alert all the time. So anyway, that was one thing. So that he said resilience is important. Up to 3 will influence how resilient you are. But how resilient you are is also, I think, genetically inherited. But that might not be true. I probably just made that up.
I think socioeconomic inheritance probably also helps.
Yes. So you've got lots of money, you can have a nice live-in nanny.
Was it Dolly Parton who said it's okay to be depressed as long as you've got enough money to spend your way out of it?
Oh, did she? I better remember that.
Something like that.
Yeah, no, she's got a point there. Oh, brilliant. Anyway, guys, that's been fantastic. Thank you so much, Kate. That's been so interesting. So anybody all last minute? No? Brilliant.
Well, I'll say something last minute.
Oh, go on then. Yeah,
just to thank you for inviting me along. And also, I just wanted to acknowledge all the people who contributed data that we used to analyse. So there's thousands of people have given their data and time again and again to help us have these wonderful data resources in this country, of which we should be very proud. But it's all thanks to them. So yeah, I just want to say thanks to them. And also, if anyone's interested in getting in touch or interested in collaborating or anything, then like I said, I'm hoping to get back into researching chronic pain. So please do get in touch.
Brilliant. Anyway, I'll just mention a little plug for our Rydal Hall meeting. It's 5th of July till the 8th of July, and it's politics, economics, and pain. So all of these things relevant to that theme, and some childhood pain as well. Hoping to get some speakers. So anyway, guys, put it in your diaries, and I'll be sending out reminders and putting the program together soon, hopefully. Brilliant. Anyway, thank you, Kate.
Thank you, Maureen.
Brilliant. It's been fabulous.
Bye-bye.
Yeah, take care. Bye now. Bye, everybody.